in the setting of having HIV and hepatitis C co-infection, the liver disease takes an unfavorable course, and that is strongly associated with the immune deficiency, which is HIV associated. So the more the CD4 count drops, the higher becomes the risk for developing relevant liver disease. So fibrosis progression is accelerated, particularly with low CD4 counts. And that's the reason why in the old days, we always recommended early treatment for HIV of patients with HIV and hepatitis C co-infection before other patient groups. Nowadays, where everyone should receive HIV treatment anyway, there is no need for prioritization. But really the hallmark of co-infection is that you have a faster fibrosis progression events and eventually death through liver disease. And in the European cohort, that is 10-fold higher than in patients who don't have HIV. So it's really an unfavorable course of liver disease in the setting of HIV-associated immunodeficiency. Yeah, so usually when we see a patient who's newly diagnosed with HIV and hepatitis C co-infection, we would first try to stabilize HIV infection. So that means we would first treat HIV, and then, because nowadays we mostly use regimens which are integrase inhibitor based, and complete control of our replication occurs usually within 4 weeks or at the latest after 3 months, we would then start with the hepatitis C treatment. You could also argue that you could treat hepatitis C first and then treat HIV, but in general, it seems better to stabilize the HIV infection, then commence hepatitis C therapy. Modern hepatitis C therapy is only 8 to 12 weeks of therapy, so is finished pretty fast, and it works very, very well with over 95% cure rate. But in general, that's our procedure. So in the setting of HIV and hepatitis C, when you choose your HIV regimen and your hepatitis C regimen, you have to be aware of drug-drug interactions. In particular, hepatitis C protease inhibitors interact with NNRTIs and PIs, which we use for treatment of HIV. So probably the best choice is to start with an integrase inhibitor-based regimen for treating HIV, as all non-boosted integrase inhibitors, which would be dolutegravir or bictegravir or raltegravir, do not interfere with hepatitis C drugs. And then after achieving undetectability, we would then start with hepatitis C therapy. And there you can really choose between preferably 2 different pan-genotypic regimens. So that would be sofosbuvir valpatisvir, which can very easily be co-administered with the integrase inhibitor-based therapy, or GP, pipentosvir, glucapavir, which can also be administered, and then depending on baseline cirrhosis, yes or no, it's 8 to 12 weeks of therapy. And I think with that, we have excellent DAA combinations, which are easily combinable. Now, if you have a patient who comes with resistance to certain HIV drugs, and you are in a very complex regimen for HIV, then treatment of hepatitis C sometimes can be challenging because of drug-drug interactions. So always make sure that you use the Liverpool website for checking drug-drug interactions between HIV and hepatitis C drugs before you start therapy.